All right. So again, good morning. I think I know nearly everybody here. Happy to be here. I'm Ariel. I'm one of the PGY4s in eMERGE. Today we're going to be talking about transplant patients in the eMERGE department. Before I get started, I have many people that I need to thank without whom putting this together would not have been possible. So first I want to thank Dr. Andy Penn, who's been my supervisor, Dr. Chris Bredesen, who is the medical director of the HEMATOPOIETIC stem cell transplant program, Dr. Stephanie Hoare, who is the medical director of the renal transplant team, Dr. Andrew Moeller, who is the heart transplant fellow and heart failure fellow at the Heart Institute, Dr. Mike Hartwick, who is the regional medical lead for Trillium Gift of Life Network, and Dr. Ariane Buchan, who is one of our new ID staff and has done her fellowship in transplant ID. So in terms of what we'll talk about today, we'll talk about our local context for transplants. As you know, we do some types of transplant at the Ottawa Hospital, but not all. We'll talk about infection in transplant patients, which is probably our predominant concern in patients who come in after transplant. And specifically, we'll talk about UTIs in the renal transplant patient. We'll talk about dysrhythmias in heart transplant patients. And then we'll talk about a few pearls around bone marrow transplant patients. I realize not all three of these transplant types are similar at all, particularly the bone marrow transplant patients who are not solid organ transplant patients, obviously. But there are some similarities among these groups. And then lastly, we'll talk about the immunosuppressant medications that some of these patients will be on, something that I was not comfortable with and hopefully will gain a bit more familiarity with. So why is it important to talk about transplant? Well, we're a center that does both heart and renal transplants and that has a robust stem cell transplant program. And we know that patients who have received a transplant are complex, in some part because of the immunosuppression that they receive, and they're at risk of multiple complications. And I realize that these are patients for whom we may be talking to the transplant service for many of their visits, but what we do in the emergency department really does matter for these patients. So delayed recognition of some complications may result in adverse effects. And if you're not able to get a hold of your cardiac transplant fellow and the patient's unstable, we need to know what to do. As Stuart Swadron says, we need to know what we need to know, and then one step further. And that's where I'm hoping to get us today. On the other side, we're also a center where many of the patients that we take care of in the emergency department and that I've had the privilege to take care of in the ICU this year end up giving the gift of life to others through organ donation. Our donor rate here is actually nearly double the provincial and national rates at about 20 to 30 donors per million population. Last month was actually Organ Donation Awareness Month, and if you go past the Civic ICU on the way to the entrance, there's a really lovely memorial wall that's new that displays the names of the patients who have, them and their families have chosen to give the gift of life. And part of honoring these patients who have donated and their families who have made the sometimes very difficult decision to donate is to take the best care that we can of the recipients of this gift. So in Ontario, according to Trillium, there were 1,269 organs transplanted in the 2017 year. Of these, 54% were renal transplants, and the majority of these were from deceased donors. Next was liver at 20%, and third was lung at 13% of all transplants. Now, at TOH, there are approximately 100 renal transplants that take place each year, and the transplant clinic follows over 1,000 patients who have been transplanted over many years. The Heart Institute performs 25 heart transplants per year, and this was actually the second highest number in the province, and they have over 350 patients that they're currently following. And our bone marrow transplant patients obviously aren't accounted for by Trillium data, but we have an ever-increasing number of patients that are being transplanted, approximately about 150 per year currently. And we see these patients often. So in a US study of patients who underwent renal transplant, 12% of them had been in the eMERGE by 1 month after their transplant, and 40% by 1 year. And these are also, as you know, high-risk visits, so about 50 to 60% of these visits ended up in hospital admission. And as you can expect, infection is the most common reason among all solid organ transplant patients to be admitted to hospital. So I want to start by talking about our highest volume population, and that's our renal transplant patients. For each of these sections, we'll start with a representative case that I'm hoping will bring up some of the questions that we'll then address. So this is a 33-year-old woman who is 14 months after her renal transplant for IgA nephropathy. She comes in with respiratory symptoms, a cough for a couple of days. She looks well. She's sent to urgent care. She's worked up. She has labs done, a chest x-ray. She really looks quite well. At some point, a urine gets sent off, it's negative. She ends up going home and being diagnosed with a viral syndrome. And then you're the QI doc 2 days later, and the urine that was sent off comes back positive for pen-sensitive E. coli. So, apologies, I know it's not the most exciting case to start the morning with, but this is a patient that, as the QI doc, you're going to have to decide what to do with this urine culture, right? So, I want to talk a little bit about the physiology of transplants first, because I think for me and for many of us, it may be a bit of a black box, and understanding what happens with transplant forms the basis for why patients are on the immunosuppressants that they are and the antibiotics. I'll give you a minute to read the comic. You can thank Dr. Syed for introducing me to Awkward Yeti, by the way. All right. So, renal transplants can come, as I mentioned, from either living or deceased donors. The kidneys are matched for blood type and for all major HLA antigens, and there's an extensive workup done prior to donation for potential malignancy in the donor kidney as well as for latent infection. At the time of transplant surgery, patients get induction therapy, which is usually a combination of high-dose steroids and either a T lymphocyte depleting agent, so that being ATG or antithymocyte globulin, or an IL-2 receptor antagonist. So big doses of immunosuppression at the time of the transplant. And the kidney is placed typically extraperitoneally in the iliac fossa, with the renal vessels anastomosed to the external iliac artery and vein, and the ureter anastomosed to a cystostomy. It's routine for the transplanted ureter to be stented, and the stent stays in place for about 6 weeks, which will become relevant later. Now, these patients now have a foreign body in them, so they need lifelong immunosuppression to avoid rejection. The most common combination of immunosuppressants for these patients is a calcineurin inhibitor, so that'll be either tacrolimus or cyclosporin, an antimetabolite, which is usually mycophenolate or sometimes azathioprine, which you'll have seen with IBD patients, and systemic steroids, so at first high dose, but then tapered over the course of a month to a dose of, for what many patients is as little as 5 milligrams daily. The risk of rejection is highest in the first months post-transplant, and over years, host graft adaptation takes place in which the donor dendritic cells presenting antigens decrease, and the host T cells are less responsive to these antigens. So that's why you may see for patients who are years out of their renal transplant that they're only on 2 immunosuppressants instead of 3. Now, with this lifelong immunosuppression also comes risk for infections, and in the short term, patients are on antimicrobial prophylaxis to prevent infection. At our center, what that means is that patients are on Septra for both UTI and PCP prophylaxis for the first 3 months, as well as either acyclovir or valganciclovir if there's a CMV mismatch between the donor and the recipient for the first 3 months. In contrast to the heart transplant patients and the bone marrow transplant patients I'll talk about later, it's not routine for these patients to be on any routine systemic antifungal. So we'll talk about infection, which is, as I mentioned, our biggest concern in patients who present to the eMERGE. Now, infections look different in this population because of the immunosuppressants that they're on, and because of slightly different physiology, both because the solid organs are deinnervated, and because, for example, in renal transplant patients, they're located in a totally different location than is normal anatomically. As our immunosuppressive regimens continue to improve, the risk of graft rejection decreases, but the risk of significant infections continues to remain high. And infection with an identified pathogen in renal transplant patients occurs at a rate of 45 per 100 patient years in the first 3 years post-transplant. Now, I'll talk on the next slide about the timing of infections and the infections we'd worry about based on the time their patients are out after their transplant, but overall, the infections that these patients get are similar to other patients we see. So, in terms of infections, UTI is still the most common infection, especially for renal transplant patients. Pneumonia is the second most common, and bacteremia is the third most common infection. Now, as you already know, these are patients we should have a very low threshold to suspect infection in, and only about 50% of patients who come in and have documented infection will have a fever. And although for most other patients, we don't routinely get excited about a temperature until it's well above 38 degrees, these are patients for whom you should perhaps consider having a lower threshold for what constitutes a fever. So in a prospective study of transplant versus non-transplant patients who were actually admitted with infection, the transplant patients for their Tmax didn't even break 38 degrees, and they also had a lower average white blood cell count. So 11 in the transplanted patients versus 15 for the non-transplant patients. So just highlighting that these patients on their immunosuppressant medications will have a blunted response to infection. Now, I told you that overall the infections that patients get are similar to the rest of the population, but especially within the first year post-transplant, there are different types of infections that we need to at least think about and worry about for these patients. This is a really nice figure from a New England Journal article back in 2007, which you obviously can't read from back there, so I've simplified it a bit. Within the first month after transplant, these are patients who have been in hospital and may be discharged, but you're still most worried about nosocomial infections. So things like hospital-acquired pneumonia, C. difficile, line infections if they still have indwelling lines, and surgical site infections. From the 1 to 6 month mark, this is when the patients are at highest risk for opportunistic infections, which makes sense given the antimicrobial prophylaxis that patients are routinely on. So in addition to all of your standard infections that you're going to think about for these patients, there are also additional considerations, including things like PCP, fungal infections, and fluconazole as a systemic antifungal doesn't prophylax against all fungal infections by any means, as well as reactivation of either host or donor viral illnesses like CMV, EBV, and HSV. And then if the patients have made it through this 1 to 6 month period, they're still at higher risk than the regular population for opportunistic illnesses, but they're also going to present with the same infections that other patients present with in terms of community-acquired infections. So in transplant patients, the messaging should be to have a lower threshold for what makes a fever and what's a white blood cell count that should make you think about infection. There are other diagnoses for fever in these patients, including graft rejection, and in the BMT patients, graft versus host disease, but this is really clearly down the road once infection's been ruled out as a consideration. And in this group, because they're at such high risk and because they also have particular resistance patterns in terms of antimicrobials, an actual microbiological diagnosis is really key in this group. What this means is that when patients come in, they'll often have more invasive testing done than other patients. And for us, what this means is that for patients who have indwelling lines especially, they need blood cultures sent. So, one blood culture is not useful for any patients, but in particular for these patients, we need multiple sets of blood cultures and to at least consider more testing than you would normally do. In patients where the concern for CMV is high, you can send off CMV PCR in the department, but this will probably be after discussion with the transplant service as to whether it would be a real concern for them. And I'm not going to make any broad statements about antibiotics, which will obviously be broad spectrum. I mentioned the concern for fungal infections, but for these patients, despite that concern, unless there's specific evidence of a fungal infection, empiric antifungal therapy is usually not indicated. So there are lots of complications to talk about in renal transplant patients, but the one I want to talk about a little bit more specifically is the concern for UTI. So UTIs are the most common source of sepsis for renal transplant patients, and they're also common. Up to 1 in 5 renal transplant patients will have a UTI by 1 year out. And the concern with UTI in this population is twofold. So one, as I mentioned, with their immunosuppression, they're more likely to get sick quicker. And two is that frequent UTIs can lead to decreased graft survival and chronic kidney disease in the transplanted kidney. Now, these patients do have slightly different bacteria when they have UTIs than other patients. E. coli is still the most prevalent bug by far, but they're more likely as well to have Enterococcus, Pseudomonas, or Enterobacter as an infective organism. And what this means is that you need to choose your antibiotics wisely. So there are actually no broad guidelines on UTI management in this specific population, and from our ID colleagues, the antibiograms that we have for UTI are actually excellent as a start. We don't have enough data numbers-wise to make specific recommendations that are actually all that much different than the general population, but I just want to highlight a few considerations for these patients. So this population from studies nationally and internationally has a high ESBL prevalence, and Dr. Hoare has also seen this in many of her renal transplant patients. So if your patient is sick and you're going to reach for our sepsis protocol, peptazovanco or ceftriaxone ampicillin, if you're going down to the UTI section, won't cover ESBL. Neither of those combinations will. So particularly if they've previously grown ESBL, you should give strong consideration to a dose of meropenem or a single dose of aminoglycoside, both of which will cover ESBL. Now, that said, our ID colleagues feel that the local data is not strong enough to warrant empiric ESBL coverage, but make sure to go back, and if the patient has ever grown it, then you should strongly consider covering. The other consideration is enterococcus coverage. So as I mentioned, this is a more common bug in this population. And if you're using ceftriaxone alone for a patient who's perhaps a bit less sick, that won't cover enterococcus. Piptazo, or if you add ampicillin onto something else, will give you enterococcus, as would Vanco at the top of our orders, or meropenem. And unfortunately, if the patient, again, is a bit more well, trusty ciprofloxacin is not an ideal first choice in this population. So E. coli resistance rates to ciprofloxacin are above 25% in this group. So the take-home message, although I apologize, can't give you any kind of hard and fast rules, are to look at our antibiograms. They're still good to use in this population, to ensure you have enterococcus coverage, and to at least think about ESBL coverage and look for if the patient has previously been positive for ESBL-containing organisms. And remember that these patients, by definition, have complicated UTIs. So if you are sending them home and they're well, they're going to be treated for more like 5 to 10 days rather than our standard 3 to 5. So if we go back to the patient that I presented to you at the beginning, this is a woman who came in with respiratory symptoms who does have a renal transplant, but she actually has what we would consider asymptomatic bacteriuria, which is also common in renal transplant patients. So about 50% of patients will have asymptomatic bacteriuria detected within the first 3 years of their follow-up. Now, the literature is really mixed as to what this actually means. There's some concern that recurrent asymptomatic bacteriuria may lead to graft dysfunction chronically. And in a small retrospective study in 2017, transplant recipients who received antibiotics for asymptomatic bacteriuria had lower rates of progression to symptomatic UTI. But absolute numbers were low, and this actually conflicted with previous studies, which showed that giving antibiotics to patients with asymptomatic bacteriuria neither prevented symptomatic UTIs or chronic renal dysfunction. There are a couple of trials ongoing now to assess the utility of antibiotics for asymptomatic bacteriuria, but we don't have any consensus, and there's not a consensus either from the IDSA or KDIGO. So in the absence of good evidence, our local practice is to treat asymptomatic bacteriuria in these patients like you would for any other patient, which is to not treat it. The only exception to this is in the patients who are in their first 6 weeks after transplant. So as I mentioned, these are patients with a foreign body in the form of the ureteric stents, and you would treat these patients. And likely you'd be talking to the transplant service as well. All right, so 10 seconds to look at this, and then we'll move on. All right, so we'll move on to a different representative case. This is a 42-year-old woman who comes in with dyspnea, which started when she was mowing the lawn. She comes in tacky at 160 with a blood pressure of 85 on 55. Her stats 92% on room air, so she doesn't really look great. And on the monitor and on your P10 ECG, she has an SVT. So the nurses are calling RT, they're getting the defib to the bedside. You decide to try a vagal maneuver, in particular the revert maneuver. Unfortunately, it's unsuccessful. Her repeat blood pressure is a little bit better. So you decide to ask for adenosine first. Your nurse is drawing up the first dose of 6 milligrams, and another nurse is undressing the patient to put the pads on in case you end up deciding to defibrillate her instead, cardiovert her, and then you find a sternotomy scar. So, I mean, you can decide how realistic this is, but the patient then is able to tell you that she had a heart transplant 10 years ago. So now knowing what you know, does this change what you're going to do with the patient who is kind of borderline unstable in front of you? Does it change how you're going to manage your drugs or your electrical cardioversion? And what do you have to think about afterwards in a young and otherwise, as far as you can tell, well patient in terms of the trigger for the SVT? So we'll again talk about a little bit of physiology. So patients who undergo heart transplant also undergo a very extensive workup prior to transplant, and surgically there's 2 main techniques for transplant, biatrial and bicable techniques. In the biatrial technique, the recipient atria are anastomosed to the donor heart atria. So this results in irregularly shaped and sized atria and can predispose them to dysrhythmias. And with the biatrial technique, the recipient SA node is preserved, which is why you may see 2 atrial impulses and 2 distinct P waves on your ECG for patients who have had a biatrial technique. For the bicaval technique, which has come more into fashion in the past 2 decades, the recipient right atrium is excised, and the donor right atrium is anastomosed to the recipient SVC and IVC, or bicaval. Now, this is thought to result in fewer dysrhythmias. At the Heart Institute, it's actually common for patients to still undergo the biatrial transplant technique, so you would expect in many patients to see that classic ECG that I showed you in the last slide with 2 atrial impulses. And typically, only the donor P wave is conducted. Now, the donor heart in either technique is denervated, which has implications for the medications in dysrhythmia that we'll talk about in a bit. Heart transplant patients also need lifelong immunosuppression, which again typically is a combination of a calcineurin inhibitor, an antimetabolite, and steroids. And as a result of their immune suppression, in the short term, patients are on prophylaxis. At the Heart Institute, this is Sectra for the first 3 to 6 months, depending on the steroid dose that patients are on. Itraconazole for the first 3 months for antifungal prophylaxis. And just as a note, this is different perhaps than many other centers because of a few cases of aspergillus after the construction at the Heart Institute was started, unfortunately. So for aspergillus, patients are on itraconazole as opposed to fluconazole, which you might see for other patients. And then valcyclovir or acyclovir, depending on the CMV positivity of the donor and the patient. So as I mentioned, the donor heart is denervated in transplant. So the sympathetic and parasympathetic chains are severed and vagal tone is lost, which means that for patients, resting heart rate is usually 80 to 110, but higher than what you would normally see for non-transplant patients. Despite this denervation, the responsiveness at beta receptors is maintained, both in EP studies and clinically. And patients rely on circulating catecholamines to raise their heart rate. In EP studies, patients are actually very sensitive to exogenous catecholamines, and they're thought to potentially have upregulated beta receptors to explain their sensitivity. Because patients rely on circulating catecholamines to modulate their heart rate, this means that they have a slower rise in their heart rate with exercise, as well as a slower deceleration once they're finished. And in studies, some partial reinnervation of the heart can occur. So in studies, about 1/3 of patients at 1 year post-transplant have some evidence of partial reinnervation. So dysrhythmias are common in the heart transplant patient, but typically transient and in the post-op period because of post-operative trauma and edema. So the one thing I'm hoping that you'll take away from this is that new dysrhythmias are not normal in the post-transplant patient once they're out from the immediate post-operative period. Now, that said, if you do encounter a post-transplant patient in the emerge and they're bradycardic, atropine will not be effective for them. But beta-1 agonists, we mentioned that they're still responsive at their beta receptors, so beta-1 agonists should work, and of course, temporary pacing is also okay. For patients who are tachycardic, again, vagal maneuvers will not be effective. And if you're going to use a rate-controlling agent for these patients, beta blockers would be preferred over calcium channel blockers because of interactions of the calcium channel blockers with the calcineurin inhibitors that they'll be on for immunosuppression. And if you're going to, as I mentioned in the case, use adenosine for SVT, which I'm hoping to convince you to be very nervous about, you should use at least half of your normal dose as an initial dose and use it with great trepidation. So although the heart doesn't have any intrinsic vagal tone, it's very sensitive to acetylcholine and to adenosine. And in an EP study that compared the effects of adenosine in transplanted patients versus native hearts, all of the transplanted patients responded to the lowest dose of adenosine that was given, and their duration of AV node slowing was 4 times the duration for non-transplanted patients. Yeah, so a longer time to be holding your breath along with the patient. Cardioversion is still safe and effective at your typical doses that you would use in terms of electricity. And then the takeaway message for these transplanted patients, if you do encounter them with a new dysrhythmia in the emerge department, is that new dysrhythmias, even if it's sinus tach with a significantly higher rate than their usual rate, is something that you need to be concerned in terms of what the underlying cause is. It's unusual for transplanted patients to develop new dysrhythmias, and you need to think about things like infection and acute rejection, as well as chronic allograft vasculopathy. So in both acute rejection and chronic allograft vasculopathy, the conducting tissues as well as the myocardium are affected. It's unusual for acute rejection nowadays to occur, especially with the immunosuppression that patients are on, and they undergo regular assessments, which may include biopsy, to rule out subclinical and pathological evidence of acute rejection, but it is a concern if they come in and they're different. Now, chronic allograft vasculopathy, or CAV, is accelerated atherosclerosis in the transplanted heart. And it's actually common to some degree. So a third of patients on studies will have some degree of CAV within the first 5 years. It's thought to be a manifestation of chronic rejection. That said, for prevention of progression of CAV, we still aim to modulate those typical atherosclerosis risk factors that we think about. And again, patients will typically undergo angiography and sometimes intravascular ultrasound to assess the degree of CAV that they have. But what this means for us is that given that CAV is so common, you may have a patient who has had a renal transplant, who is otherwise young, in whom you might not think of ischemia, who has a heart that's denervated, so the rule would be that they will not have chest pain when they have ischemia, and nevertheless, they do have an ischemic event. So I mentioned that hearts can become partially denervated, so it won't be all patients who will present atypically and without any chest pain, but it would be the rule that for patients who come in after a heart transplant and have ischemia, that they would have atypical symptoms. So in terms of CAV and in terms of ischemia, you should think about dyspnea, new heart failure, and new dysrhythmias in terms of ischemia. All right, so for heart transplant patients, we talked about using beta blockers over calcium channel blockers if you're dealing with a tachydysrhythmia. We talked about at least having your adenosine dosing if you're going to actually use it. We talked about atypical symptoms being the rule for ischemia, and that new dysrhythmias should really make you talk to our transplant colleagues, and this was universally the case for all of our transplant docs that I talked to. They have a great deal of time and energy and emotion invested in these patients that they know well and are very happy to hear about them when they're in the emergency department and discuss the best way to manage them. All right, so last representative case. This is a 23-year-old man who is 5 months post-bone marrow transplant for NHL. He comes in with mild abdominal discomfort and watery diarrhea. He's actually reconstituted his immune system. So he has a normal white blood cell count, normal lights. He is in OB, but overall looks fairly well. So what are the considerations that you should think of for this guy beyond viral gastroenteritis? So again, a bit of physiology. So hematopoietic stem cell transplants are being performed for an ever-increasing number of indications. The classic indications were for hematologic malignancy, so things like ALL, CLL, multiple myeloma, Hodgkin's, and non-Hodgkin's lymphoma. But if you've read about the work being done at the Ottawa Hospital, in particular Dr. Harry Atkins' work, you'll have seen that stem cell transplants are being performed for a number of autoimmune indications as well, including MS, stiff person syndrome, scleroderma, and many others. And bone marrow transplant comes in two varieties. So either autologous, which is the patient's own bone marrow, but is typically not done for hematologic malignancy and avoids the risk of graft versus host disease, or allogeneic, which is either a related or unrelated donor and matched for HLA alleles. Now, the idea with bone marrow transplant, particularly for malignancy, is that the donor cells will reconstitute the patient's immune system. And in the case of hematologic malignancy, we'll ideally have a graft versus tumor effect and attack any remaining cancer cells. The typical procedure for patients who are coming in for a bone marrow transplant are that in the week prior to their transplant, they'll undergo conditioning. So this is usually high-dose chemotherapy and sometimes total body irradiation to kill any cancer cells and the recipient bone marrow. On day 0, they'll undergo transplantation, which is the infusion of their stem cells, and then they sit and wait for engraftment, which is for those stem cells to take up in the bone marrow and start producing their own cell lines. And typically, if everything goes well and there are no intercurrent illnesses, this will occur around 12 to 30 days. So there's a period of time before and after transplant where patients will be very significantly neutropenic. And then immune reconstitution occurs over weeks to months, and patients are considered really significantly immunosuppressed for at least the first 6 months after their transplant, even if they've recovered their counts and are no longer neutropenic. So this is for a few reasons. Patients in the short term are on immunosuppressants to prevent graft versus host disease. And these are kept on board until the patients recover their counts. And weaning of those immunosuppressants starts around 2 to 3 months, as long as there's no evidence of graft versus host disease. So these patients, in contrast to the others, will typically not be on lifelong immunosuppression. And the immunosuppressant of choice for these patients really varies widely with the indication for transplant and the health of the patient around the time of transplant. Similar to the other transplant types that we've discussed, patients are on antimicrobial prophylaxis around the time of their transplant. And for these patients, they're on their antimicrobials for longer. So they're typically on acyclovir for a year, Septra for PCP prophylaxis for a year, and fluconazole for the first 3 months. And again, fluconazole will not cover them for all types of fungal infection that we talked about in that 1 to 6 month period. So I mentioned that patients are really significantly immunosuppressed for at least the first 6 months to a year after their transplant. And it might surprise you to know that these patients actually need to be completely revaccinated. So this isn't actually started until about 6 months to a year after their transplant, and is another reason to keep a really broad differential for these patients for the infection-related symptoms that they may come in with. Now, if the transplant's successful, patients actually will regain relatively normal immune systems. At around 2 years out, patients who aren't on ongoing immune suppressants for GVHD are thought to have immune competence. And in long-term studies, so patients who have had their transplant for 20 to 30 years out, they're thought to have totally normal immune systems, both in terms of the infections that they present with and in studies of their circulating T cells. Now, that said, unfortunately, not all patients will have smooth sailing after their transplants. They're at risk of multiple complications, and they're at risk of relapse disease. And the main message from Dr. Bredesen and his transplant colleagues is that in terms of our emerge management, a BMT patient who is peri-transplant or post-transplant and comes in with neutropenia and fever is obviously a medical emergency who, even if they're in OBS, needs very early antibiotics. So BMT patients, neutropenic or not, will come in frequently with respiratory symptoms, and lung infection is the most common documented infection in this population. And for respiratory symptoms, the workup needs to be broader than for most other patients. As I mentioned, patients aren't fully immunized for 2 years after their transplant, and they're on immunosuppressants, which puts them at risk of fungal infections as well. And the BMT service likes to know which virus they're dealing with, if they're dealing with a viral infection, and it's also really important for them to be able to tailor their antibiotics if there's a specific infective agent that the patient has in terms of a pneumonia. So what this means from us is that in flu season, patients should have a respiratory virus panel in addition to their influenza swab sent off to CHIO. This is routine for the BMT service. And you should also consider sending off a sputum if you're able. For patients who are sick and going to come into hospital, many of these patients will actually need bronchoscopy, which is the only way to identify a pathogen in up to a third of patients with breast failure. But there are a few things in terms of broadening our workup that we can do in the emerge department. And for BMT patients who present with GI symptoms, the differential is wide. There's a few additional considerations infection-wise that we wouldn't normally think about in immune-competent patients, including typhlitis for the patient who's neutropenic, and GI illnesses like strongyloides and cryptococcus that would only present in very immunosuppressed patients. However, common things being common, C. difficile in these patients who are in and out of hospitals should still be high on your differential. And I just want to mention briefly graft versus host disease, which most commonly presents with diarrhea. So this is when, for allogeneic stem cell transplants, the T lymphocytes of the donor graft attack the recipient tissue. Due to antigenic differences between the donor and host major histocompatibility complexes. So GVHD can be either acute within the first 100 days after transplant, or chronic, which is either developing or persisting after 100 days. And it typically presents with some combination of rash, diarrhea, abdominal pain, cholestasis, and transaminitis. And it's graded. And the reason I think it's important for us to know about GVHD in the emergency department is that for patients who do have GVHD, they'll be on prolonged courses of immunosuppressants. So again, your BMT patient may have normal counts, but these patients may be on even longer courses of immunosuppressants, increasing their risk for opportunistic infections. All right, so home stretch. As I've mentioned in previous sections multiple times, most transplant patients will be on a combination of immunosuppressants. And I'm just going to talk about a few of them today. So many regimens, particularly for solid organ transplant, will consist of a calcineurin inhibitor, which will be either cyclosporin or tacrolimus, an antimetabolite, which will usually be azathioprine or mycophenolate, and a steroid. And I just want to briefly talk about these immunosuppressants that we may encounter. I'm not going to say anything about steroids except to remind us that for patients who are sick who come in, you want to think about at least doubling their steroid dose or giving them stress dose steroids. So you can think about the calcineurin inhibitors, which are tacrolimus or Prograf or cyclosporin, as antiproliferatives because they inhibit the intracellular signaling pathways, and in particular the IL-2 release that's necessary for the proliferation of cytotoxic T cells that would otherwise attack the transplant. Now, the dosing of these drugs is based on serum level, and the serum level that we target is dependent on the time post-transplant that the patient is. In patients who are sick, their drug levels may be altered, and the dosing might have to be changed when they're sick. But this is actually, as opposed to, for example, phenytoin, something that it's not helpful for us to get a random level of in the emergency department. So levels for both tacro and cyclosporin are drawn as a trough level before their morning dose is given. So if the patient is due to take their dose, it may be helpful to get that level, but otherwise a random level is not at all helpful for dosing. The main toxicities for these meds that I think it's helpful for us to know about are that the calcineurin inhibitors are well known for hypertension and have been associated with hypertensive emergencies and with PRES. They're also nephrotoxic, and they can be neurotoxic, including causing seizures and tremor. Tacrolimus is a newer med than cyclosporin, and so it's associated with fewer metabolic side effects, but it's still well known to be a nephrotoxin and has been associated with hypertension. And notably, these drugs are metabolized by the liver and the CYP450 enzyme system. So there is a huge list of medications that will interact with the calcineurin inhibitors. There's just a few that I'm going to highlight that are drugs we may use in the emergency department. So as I mentioned, calcium channel blockers will increase calcineurin inhibitor levels, which is why, as I mentioned in the heart transplant section, it would be preferable to use a beta blocker if you're going to use something for rate control. And in terms of antibiotics, so macrolides will inhibit CYP3A4, and increase the metabolism of these drugs, and decrease their metabolism and increase the levels of these drugs. So, for example, if you have a patient who is well and going to go home with a script for outpatient management of a pneumonia, you might want to think twice before sending them home with a script for azithromycin. The recommendation from the American Society of Transplant is actually to avoid macrolides if you have a different choice. Now, I mentioned single-dose immunoglycosides as a consideration for ESBL coverage earlier in UTI management, and the immunoglycosides will enhance the potential nephrotoxicity of the calcineurin inhibitors, but typically when given in prolonged dosing, which is very different than our single dose, which we'll use for gram-negative killing in the emergency department. And phenytoin will decrease calcineurin inhibitor levels. But again, if this is a patient you're going to give IV phenytoin to, they'll very likely be coming in, and we'll be able to monitor their levels when they come in. Okay, lastly, I just want to talk about MMF or Cellcept, which is a common antimetabolite that you'll see patients on. This is a prodrug that releases mycophenolic acid, which inhibits purine synthesis that's needed for lymphocyte proliferation. Good news, there's no drug levels that you need to guide dosing of this drug. The main toxicities are GI toxicity and myelosuppression. So just for us to know that for patients who come in and may be anemic or may be neutropenic, this is a drug that might actually get stopped when patients come into hospital and are sick. All right, so I just want to summarize in terms of takeaways from today. So we talked about a lot of things. We talked about infection post-transplant. We already know that this is really high risk for patients who are on immunosuppression. We talked about having a lower threshold for what might actually make a fever in these patients, and having a low threshold for doing testing, including blood cultures and potentially stool cultures as appropriate. We talked about UTIs in the renal transplant patient. So these are frequent and can lead to chronic rejection if they're untreated. We talked about considering ESBL and enterococcus coverage in choosing your therapy and using our local antibiograms as your best line for what's appropriate treatment. We also talked, so despite these concerns about UTIs in the renal transplant patient, we talked about not treating asymptomatic bacteriuria, except in the first 6 weeks after transplant. And in terms of arrhythmias in the heart transplant patient, I hope I've convinced you to be very worried about them. Cardioversion and beta blockers are still safe, but you should think about changing your dosing of both sympathomimetics and adenosine if you're going to be using them, and to consider acute ischemia and CAV as a potential cause for that dysrhythmia. In terms of BMT patients, so we know these are high-risk patients, even if their counts are normal, for multiple reasons. We talked about thorough testing for these patients and broad-spectrum antibiotics, particularly if they're neutropenic. And in terms of the immunosuppressant medications, so there are lots of interactions. There are lots of good resources that you can look at to assess for if there are interactions with the drug you're going to be starting. But to at least consider choosing something different than a macrolide in terms of your antibiotic therapy in the emergency department, and ensuring the patients have follow-up 4 levels if appropriate. And lastly, just a plug to work with our colleagues who have so much experience with these patients. Again, everyone I spoke to was wonderful, has lots of interest in hearing about these patients. They develop long-term relationships with these patients and follow them very closely, so they're all very happy to be involved. And that was reinforced to me by all of them. Just lastly, I'm going to put up 3 websites to go to if you're interested in learning more about the process to register your wishes to be an organ donor, or to register with the last link in our National Bone Marrow Registry. I'd like to really thank all of the people who helped me to put this together, and I'm happy to take any questions.